All right. Good Wednesday morning to everybody. I say this is always an elite crowd. We don't let just anybody come and attend at this point. And I think we're going to see some people trickling down from the other session up at Hacienda after they grab some coffee. So we'll start by, this isn't fair, but a quick quiz. How much time, what's the deadline for claiming CME? 1 month. Good job. Dr. Albrecht, good job. So yes, 1 month. So 1 month from today is May 19th. So you've got a 1 month deadline. I'm also reminded that the meeting will be available on recording. So if there's something you missed or something you want to hear again, you can also go to the website and do that. Safe travels. Please make plans to join us next year. It's actually a typo. It says makes plans next year to join us in Ojai, California. It would be nice. I think we'd enjoy being back here. I think we've had a great time, but the annual meeting is April 21st through 24th at the Hyatt Regency Tamaya in what state? New Mexico. Oh, everyone's doing so well this morning. That's terrific. Anyway, I won't take any more time. We are going to go to the next scientific session. Doctors Tominaga and Barrios are here ready to begin, and we'll let them take it away.
Thank you, everybody, for coming to the last session and hanging in there. The first talk we're having this morning is a APP award finalist. It's Below the Knee, Let It Be, Management of CAF, DVT, and Hospitalized Trauma Patients by Annika Kay.
Thank you for the privilege of the podium and for being here early, everybody. I have no disclosures. So most DVT originate in the calf, in the infrapopliteal veins of the lower extremity. And while the consensus for the management of above knee DVT with therapeutic anticoagulation and IVC filter for the prevention of PE is there, the management of below knee DVT is unclear. This is largely due to limited data in the trauma population. Most of the data looking at calf DVT management is in either medically ill patients or outpatients, which really has limited applicability to trauma patients who undoubtedly have a magnified competition between risk of VTE and risk of bleeding. Furthermore, the traditional embolic relationship between DVT and PE has been questioned in the trauma population. The American College of Chest Physicians recommends serial duplex imaging with ultrasound in patients without risks of extension. This is a low grade recommendation, and they also don't specify what those risks of extension might be, i.e. who would qualify for something escalated above ultrasound. So given the clinical equipoise that exists between observation with ultrasound and therapeutic anticoagulation, both approaches are considered acceptable for the management of a distal DVT. So in preparation for a randomized control trial that we undertook back in 2017, we wanted to make sure that all of our VTE management protocols were refined. At the time, or kind of prior to that, the management of below knee DVT was really at provider discretion, and we changed it to observation with serial ultrasound at 2 weeks post-discharge. So our hypothesis was that below knee DVT can in fact be safely managed with observation only. So this is a secondary retrospective analysis of our original randomized control trial on routine surveillance that enrolled at-risk trauma patients from March 2017 to September 2019. Patients were eligible for randomization if they were admitted to our service and had a risk assessment or RAP of greater than or equal to 5, which is a VTE risk tool, if you will. Patients were excluded if they were underage, pregnant, had a recent VTE event, or had a chronic hypercoagulable state. For this population, for this analysis, we included anyone who had an in-hospital DVT diagnosed and included below knee and above knee in this analysis. We defined propagation as an initial below knee DVT that then propagated to an above knee or had an associated PE. And our routine surveillance in patients who received that was an ultrasound on days 1, 3, 7, and weekly during hospitalization. So we compared below knee DVT patients, just their characteristics, to above knee DVT patients. Were there any differences there? We looked at below knee DVT progression and compared those patients to those who did not experience progression. We wanted to look at our adherence rate to our protocol, and we set the alpha at 0.05. So out of about 2,000 patients, 1,998, we had an 8% in-hospital DVT rate. 6.8% were below knee DVT and 1.2% were above knee DVT on initial ultrasound. Comparing those who had a below knee to an above knee on initial ultrasound, the below knee DVT patients were significantly less likely to be on pre-injury anticoagulation. They had a longer time to diagnosis, about 1.5 days. So between that, day 1 and day 3 ultrasound, whereas the above knee DVT were found primarily on the day 1 ultrasound. Below knee DVT patients were significantly more likely to be in the routine surveillance arm of our trial. Not surprisingly, they were less likely to receive therapeutic anticoagulation. There was 0 incidence of post-thrombotic syndrome reported overall. And while the rate of in-hospital PE was lower in the below knee DVT group, this was not significantly different. And then hospital length of stay was similar. So of the 101 patients who received a second ultrasound, they were included in the analysis on progression. We observed a 6.9 progression rate. 3 had an above knee DVT, 3 had just a PE, and then 1 patient had 1 of each. And so looking at the 7 patients who progressed, comparing them to the rest of the population, we found that progression patients had a significantly higher ISS of 36 compared to 21.6. They had a little bit more in the way of ultrasound tests. Their time to prophylaxis initiation was significantly delayed, about 5 days compared to just under 2 days in those who did not progress. And their hospital length of stay was significantly longer. I wanted to look at the patients in the below knee DVT group who underwent treatment. This was really kind of looking at our protocol adherence. 11 patients received therapeutic anticoagulation, 5 received an IVC filter, and you can see here the indications, none of which were initiated for prophylaxis or at provider discretion. And so I think all very appropriate. So limitations, this was a retrospective review for the purpose of a secondary analysis, not originally powered for this outcome. 1/4 of our patients did not receive a second ultrasound, and so certainly the rate of progression could have been underreported. We did not look at post-discharge anticoagulation medications, and so if a patient was placed by their PCP or someone on therapeutic anticoagulation for their calf clot, we would not have known that. PTS or post-thrombotic syndrome was 0. So that only tells me it was probably underreported. And then we certainly could have missed patients who were presenting to facilities outside of our hospital system and missed longer term events that way. So in conclusion, the majority of isolated below knee DVT did not in fact progress. And those that did progress was associated with a significantly higher ISS, a longer delay to prophylaxis initiation, and a significantly prolonged hospital length of stay, all of which presumably are associated with risks of bleeding that would preclude the safe initiation of therapeutic anticoagulation. And so we therefore deem this an unavoidable and acceptable risk. Observation was also not associated with risk of PE or thrombotic sequelae. And so we are considering replacing whole leg ultrasound with proximal leg. So we therefore think that observation for the management of below knee DVT is the most practical approach in these severely injured trauma patients. Future investigation on how to manage these patients, whether or not there is a role for therapeutic anticoagulation in a subset or even extended duration chemoprophylaxis in these patients, is warranted. Thank you. That's my house.
Discussion, we'll invite to discuss this Dr. Frank Wood from the University of Oklahoma.
Good morning. I'd like to congratulate you on your work. Thank you for getting to me early, and I'd like to express my appreciation to Southwest Surgical for the opportunity to discuss this. I have 3 questions for you. What does your institution primarily use for DVT prophylaxis? Is it enoxaparin or heparin? Do you routinely, if so, and you use enoxaparin, do you routinely monitor levels such as following 10A levels and adjust dose respectively, or do you just do weight-based dosing alone without monitoring? Next, for those with below knee DVT that progressed, Were all of these progressions symptomatic or incidentally found on imaging? And 3, given the very low rates of progression for below knee DVT, would you still advocate for your current screening process for patients with a risk assessment profile greater than 5 versus no screening versus selecting screening for high injury severity scale, which it appears your study and some others that you cited in your discussion show appears to be more important for progression?
Thank you, Dr. Wood. I appreciate your questions. So number one, our primary in-hospital agent is low molecular weight heparin. And we do have a protocol in which we weight base low molecular weight heparin in obese patients. We will check anti-10A levels for extremes of weight, so less than 50 kilos and greater than 150 kilos. But if they don't have significant bleeding risks and they have normal creatinine clearance and all the other things, we will weight base them without anti-10As. Looking at the patients that progressed, were they symptomatic? So there were 7 patients, 4 of whom had PEs. And so yes, we presume that those are symptomatic because we only detect those based on symptoms. The majority of below knee DVT patients were in the routine surveillance group. So you can assume that those were likely asymptomatic and that progression was just found based on the routine surveillance, but there's no way to know because I've spent hours looking over these charts and no one documents anywhere that there is any symptom of a VTE. So that's just hard to answer that question. I don't know the answer to that. I think that'll be hard to glean. That's a great question about our protocol. So we published a secondary analysis looking at on our original trial, also looking at the utility of the RAP and how good is it at defining patients who would best benefit from routine surveillance. Our trial found a PE reduction that was significant with routine surveillance, but we wanted to refine it further. And we found a threshold of the RAP of 8. So we changed our protocol to recommend that anyone with a RAP score of 8 or anyone who had blood transfusion with an operation, because those were 2 independent risks that shook out. Usually if you have those 2, you also have a RAP of 8 unless you're 20 maybe with an isolated pelvis or something. So that's our new kind of a refined protocol for who we survey. And then I also said that I have a bias in that we should probably move from whole leg to proximal leg. That has some implications with our PV lab, but so that's the direction that we're moving.
Okay, Dr. Biffle.
Walt Biffle, San Diego. First, I want to congratulate you, not just on this presentation, but on all of the presentations you've given here and your ability to keep everything straight in your head. And because you reminded me that I asked you a question previously when you presented on this, I felt compelled to come
Thank
up
you.
here.
10 years ago, here we are.
So in your initial study, you concluded that larger studies are warranted to assess basically the value of ultrasound screening and the outcomes of these patients. And in the 3 or 4 years since that trial ended, and this is a study of the initial database, but have you tracked these patients and are you still doing it all the same way? And are the outcomes the same? Do you have data on that?
Yeah, thanks for that question. We are tracking those patients. I have not seen the numbers, but as I just kind of alluded to, we have refined our protocol for surveillance as I described. And so we have a pretty robust VTE database. We do plan on looking at that. I kind of had like a 5-year mark in my head, but we need other centers who want to do this with us because of course it's such a low event rate that we need larger trials. So let me know if you're interested.
Thank you very much.
Okay, thanks.
Will be efficacy of incisional negative pressure wound therapy in preventing post-sternotomy wound infections, to be presented by Lawson Traylor.
Hello, everybody, and thank you for this opportunity to talk here. So sterile wound infections remain a significant source of mortality and morbidity for patients who undergo median sternotomy for cardiac surgery. In the literature, the prevalence of this complication is between 1% and 6%. However, it represents a mortality rate of 7 to 35%. So it remains a large issue. And despite attempts to prevent these from developing, including things like preoperative nasal decontamination, topical agents, et cetera, they remain a issue despite all that. So we looked at the use of negative pressure wound therapy applied to the incision site because it has a clear role in treating sterile wound infections. However, its use in preventing their development has not been clearly elucidated. So we employed a retrospective analysis in August of 2018. Our center started implementing a uniform wound care protocol. Before this point, it had been ad lib, and after that, we applied the same wound care protocol to all patients, which included the universal use of a negative pressure wound therapy system. And so we compared these two trial periods, and we looked at this through looking at our data from the registry for the Society of Thoracic Surgeons. Our inclusion criteria was anybody who underwent cardiac surgery with median sternotomy, and we excluded any patients who had a non-conventional sternotomy, who had mortality within 7 days of the index operation, or who had a delayed sternal closure. Our primary endpoints were any developments of sterile wound infections within 90 days of the index operation. And we had secondary endpoints of a shorter time period of infection, mortality, and readmission. And as I said, our standardized wound care protocol involved the use of antibiotics, an Acticoat silver dressing, and the Prevena wound care system. The first Prevena was placed after surgery, and that was changed at either day number 7 or the time of discharge and replaced by a second Prevena, which was then changed after 7 days by either the in-facility nursing staff or home health. The demographics of our study are shown. We did have a difference in the median or the mean age of our patients and the ratios of females to males. And in addition, excuse me, in addition, there was a difference in the percentage of patients who had diabetes and CHF. Our outcomes are shown here. So our primary endpoint for development of SWI within 90 days was shown to be significantly lower in our intervention group. And there's also shown to be a significant difference for sterile wound development within 30 days, as well as just any sterile wound infection, regardless of whether it met the STS criteria or not. For the patients who did develop a sterile wound infection within 90 days, the characteristics are shown. So there, again, was a difference in the age group, with a higher age being associated with this, as well as the gender of the patient, with a higher rate in females, higher rates in people who are current smokers, and those with lung disease. After this, we applied a multiple logistic regression analysis to determine the independent predictors of developing a sterile wound infection. And again, the female gender, current smoking status, and diabetes were associated with increased risk. And the use of a negative pressure wound therapy system as part of a universal wound care protocol was shown to be an independent predictor for a decreased rate of sterile wound infections with an odds ratio of 0.25. So the limitations of this study is that it was a retrospective study, that it was a single institution study, and that because sterile wound infections are not the most common complication afterwards, there was a low pre-intervention prevalence to gain insight from. However, the prevalence that we observed was consistent with what was found in the literature. So as I said, the prevalence that we found was about 3%, which is consistent with what was found in the literature. And this was decreased to 0.8% after the implementation of our universal wound care protocol. In addition, there was also a decrease in the rates of sternal wound infections within 30 days and a decrease in the rate of infections by any definition, as well as debridements and muscle or mental flaps. So with this sternal wound infection, or the negative pressure wound therapy system has some clear potential for preventing these from developing, as well as additional benefits such as increased wound healing and decreased scar formation. So in conclusion, the universal wound care protocol for negative pressure wound, including the use of a negative pressure wound therapy system, was an independent predictor of decreased rates of sternal wound infections. And from the data, we can glean that it has the potential to not only treat, but prevent these infections from developing and should be considered for all post-sternotomy patients. These references. So, and thank you.
Discussion for the paper will be Randeep Jella.
Hello. Thank you for the privilege of discussing this paper. I very much enjoyed reading your paper. I have several comments and clarifications on terms of the paper. The first is, in terms of the comprehensive protocol, was it able to tease out what specific components of the protocol may have influenced it? The changes, I get the Prevena is one part, the Acticode is another part. How much of the changes that you saw could have been due to the Acticode itself or other components of the changes in the wound care protocol? The second question is, it focused on the Society of Thoracic Surgeons in terms of what was defined as sternal wound infections. And my understanding is that is primarily deep sternal wound infections. If that is the case, what was the organism? And did you see any difference in superficial sternal infections? I know you had one all, I don't know if that's including superficial as well as deep deep site. And in the paper itself, it also mentioned something about a non-conventional sternotomy. I was just wondering if you could clarify that. Again, it's a very interesting paper and it shows that the benefits of your comprehensive wound care protocol are.
Thank you. And thank you for those questions. So for the first one, one of the points of the paper that we think needs further investigation is that, as you said, this did come after the use of a universal wound care protocol, including the Acticode dressing. So it's something where we cannot solely contribute it to the negative pressure wound therapy system. However, the protocol that we implemented, the largest difference in that is the use of negative pressure wound therapy systems. So it's suggestive that there is, however, we were not able to clearly point to that in isolation and as a point of further investigation. For your second question, the STS registry definitions, like you said, they are typically more associated with deep sternal wound infections. We use those because that was the registry we were pulling the data from, so to make sure everything was consistent. However, we did see decreased rates of the superficial infections as well, which is why we included that category of any infections, as well as debridements or muscle flaps, to make sure we capture things where there may not be gross purulence or positive cultures, but there's still clinical signs of a sternal wound infection. And to your third question, the non-conventional sternotomies are things like partial sternotomies or things like that instead of a complete sternotomy. Okay.
Presentation, thank you.
All right, thank you.
Next presentation is outcomes for advanced age 35 and older versus younger age pregnant trauma patients, a multi-center trial by, I hope I pronounced it right, Nagar Orion from UC Irvine.
Hello, everyone. I'm Nigar Aryan, and we would like to thank Southwest Surgical for the privilege of the podium. So we have no disclosures. The prevalence of advanced maternal age pregnancies characterized by women aged 35 years or older has increased by 23% since 2000. Advanced maternal age pregnancies are more susceptible to non-traumatic complications such as preeclampsia and have a higher risk of preterm birth and maternal and fetal mortality. Also, advanced maternal age patients have a higher rate of preterm fetal delivery. Trauma is a major non-obstructive factor contributing to maternal and fetal morbidity and mortality. Managing prenatal trauma patients poses unique challenges as both the mother and fetus face potential risks. Many obstetricians consider advanced maternal age pregnant trauma patients higher risk and observe these patients for longer periods of time after trauma for potential fetal delivery. To evaluate whether advanced maternal age pregnant trauma patients are at higher risk compared to younger pregnant patients, we compared these groups and hypothesized that advanced maternal age pregnant trauma patients have a higher rate and risk of fetal delivery compared to younger pregnant trauma patients. This was a post hoc analysis of a multi-institutional retrospective study conducted between 2016 to 2021 across 12 trauma centers. We included all pregnant trauma patients 18 years of age or older. The primary outcome was fetal delivery, and the secondary outcomes included length of stay, ventilator days, and mortality. Data collected included demographics, vitals on arrival, and the injury profile, including the injury severity score, as well as laboratory findings when performed. Bivariate comparisons were used to compare advanced maternal age versus younger pregnant trauma patients. In addition, we performed a multivariable logistic regression analysis to identify if advanced maternal age versus younger maternal age was associated with increased risk of fetal delivery when controlling for the variables listed here. And these were determined based on literature review. This table shows the demographics of the patients. From 950 pregnant trauma patients, 114 or 12% presented with advanced maternal age. Advanced maternal age patients had a median age of 38, and the younger cohort had a median age of 26. Both groups had a similar gestational age and incidence of all mechanisms of injury. Notably, MVC was the most common mechanism in both groups. There were also no differences in terms of vitals, fetal heart rate, and exam findings, except the advanced maternal age, except the younger cohort more commonly had abdominal tenderness. In regards to the injury profile, both groups were relatively uninjured. However, the advanced maternal age patients had higher rates of stomach, pancreatic, and bladder injuries. In terms of laboratory data, there were no significant differences except for increased urine THC positivity in the younger cohort. Regarding the primary outcome, there was no difference in the rate of fetal delivery between cohorts. All secondary outcomes were also similar between cohorts. After adjusting for known predictors of fetal delivery, advanced maternal age was not associated with increased risk of fetal delivery compared to younger pregnant patients. Variables associated with increased risk of fetal delivery included abnormal fetal heart rate patterns, premature rupture of membranes, and placental injury. Fetal delivery after trauma has previously reported rates ranging from 11 to 38%. We found a more modest rate of 6.6%, and advanced maternal age was not associated with fetal delivery. No prior studies have specifically compared advanced maternal age versus younger pregnancies regarding fetal delivery. Thus, our findings are novel. However, Cert et al. Performed a single-center study and found that advanced maternal age was associated with increased obstetric complications, although this included fetal distress without delivery. In contrast, Melamed et al. Supported our larger multicenter findings that there is no association between advanced maternal age and complications. As the first study to report differences in injury patterns between advanced maternal age and younger pregnant patients, we found an increased rate of pancreatic, gastric, and bladder injuries in the advanced maternal age patients. Prior studies have found differences in physiologic changes such as hormonal levels between advanced maternal age and younger pregnancies, which may explain the differences seen in this study. Alternative reasons could include differences in urine toxicology or increased comorbidities in the advanced maternal age patients. Limitations to this study include those inherent to a retrospective design and lack of pertinent variables, such as cause of maternal complications. Also, this study lacks long-term post-discharge maternal and fetal outcomes and information regarding social determinants of health, which may affect maternal outcomes. In conclusion, advanced maternal age is not associated with increased risk of fetal delivery compared to younger pregnant patients. While advanced maternal age patients more commonly had injuries to the bladder, pancreas, and stomach, and they had similar rates of mortality and complications compared to younger pregnant patients. Thus, we recommend that while advanced maternal age patients may be more susceptible to certain abdominal injuries, they can be counseled to have a similar risk of fetal delivery compared to younger pregnant patients, and do not require increased observation for fetal delivery inherent to their advanced maternal age status. Thank you. I will be happy to answer any questions.
Thank you. Our invited discussant is Dr. Sean Nix.
Good morning. Thank you, Southwestern, for giving me the opportunity to read this great paper, and congratulations on a well-written, fun to read paper. And it is an important topic, as you pointed out, with the increasing age of first pregnancy, in our population is something that we do have to think about. And as trauma surgeons, we do get a lot of maybe need to observe this patient just because and so on like that. But it had a few questions, nothing really major that I found in the paper, like I said, it's well written. One of the things just in one of your tables, it said the advanced maternal age patients had a higher rate of long-term care discharge. I was wondering if you guys speculated or had any data as to why that was. I mean, 35 is not that old, believe me. And the other thing in your conclusion about stomach, pancreas, and bladder injuries, that was kind of interesting conclusion. Both had similar ISS 25, so fairly sick. But then when we looked at the actual raw numbers, it was a difference. In one group, it was one patient versus two, and another injury, it was 2 versus 2. Another one was 2 versus 2. P-values were significant. Totally understand. And you kind of speculated in your discussion that this could be to decorticalization and osteoporotic bone or something like that, just weaker bony cage of the older women, but you didn't report any increase in fractures. So when I look at that data, I just kind of wondering, is this really a sampling error? Just 1 or 2 patients difference. It's just hard for me to draw a conclusion on that. And then kind of segue into, did you consider separating blunt versus penetrating injuries in these patients? I saw the younger patients had more penetrating, almost exclusively, than the older patients. The National Registry does track pregnancy. And so I kind of wondered why we restricted one geographic region and you didn't decide to query that. And then multivariate analysis, looked at some of the risk factors for fetal delivery in the pregnant trauma patient. And a couple of them, like PROM, abnormal fetal heart rate, kind of wonder if you guys looked at how much different those risk factors are in trauma patients as for any pregnant patient who comes in with PROM and abnormal heart rate and their rate of early labor. And then I just, for completion, wondered if you guys had thought about including domestic violence in this as just part of the analysis. Anyway, but thank you for letting me read it. It's a good paper.
Thank you very much, Dr. Nix. These are all very great questions. So regarding your first question about the long-term acute care facility discharge, I can say that yes, so absolute numbers for the patients that were of advanced maternal age patients that were discharged to a long-term acute care facility were very low. So this may be just skewed. So we are planning to do a larger multi-center study to evaluate this and see if actually this is accurate. Regarding your second question about the sampling errors, we do acknowledge that this could be true, and to actually combine it with your question regarding the national analysis, I can say that we are actually part of a larger national retrospective study right now, and we are planning to confirm our studies by being in this group. And in the future, we are also planning to do a prospective multi-center study and analyze the outcomes of maternal and fetal post-discharge outcomes. Regarding your question, which was very interesting for the risk factors for the non-trauma patients, in our literature review on the literature review that we did on this study, there was actually a very significant overlap, with the only difference being advanced maternal age in this studies, which were done by many non-trauma patients on advanced maternal age patients. And for your last question regarding the domestic violence, actually it was a very interesting topic to us as well. And we did actually do a separate manuscript on this paper because we thought that this deserves a special, it requires a special, how do you say it? Attention. So we are submitting the paper very soon. And also you asked about the blunt and penetrating trauma. We were planning to do a subgroup analysis for the penetrating trauma patients, but the number of patients with fetal delivery in this group were very low. So we did not do the subgroup analysis, but as I said, we are in a larger multi-center study right now, and we are planning to find the answers for these questions. Thank you very much for I hope I could answer your questions. Thank you.
Thank you.
Thank you.
Thank you. Next is a Jack Barney finalist paper, to observe or not to observe evaluation of the modified brain injury guideline management of small volume intracranial hemorrhage by Dr. Janet Lee.
All right, good morning. I would like to thank Dr. Tominaga, Barrios, Regner, members and guests for the opportunity to present our work. I have no disclosures. Traumatic brain injury accounted for 2.5 million emergency room visits and over 280,000 hospitalization in the United States in 2013. And the number of TBI-related ED visits are steadily increasing, which causes significant strain and costs to our healthcare system. The advances of CT scans and its ubiquitous use in the trauma settings has also increased a detection of mild or even small intracranial hemorrhage that does not entail clinical significance. Many efforts have been made to reduce routine unnecessary interventions to improve care and decrease costs in TBI population. The brain injury guideline is an algorithm that stratifies traumatic brain injury into 3 categories based on its clinical and radiographic findings, and offers management based on its severity. The modified brain injury guideline is a modified algorithm from the big brain injury guideline that aim to improve patient care and redefine definitions of the brain injury guideline, some of which include removal of epidural hematoma from big 1 and 2 categories, providing more specific definition for subarachnoid hemorrhage and alcohol intoxication. The study institution uses modified brain injury guidelines to provide care for traumatic brain injury population. Patients who have mild intracranial hemorrhage, those who meet MBIG-1 criteria, are managed without routine repeat head CT unless clinically indicated and neurosurgical consultation. They're observed in the emergency room for 6 hours, and if they have GCS of 15 and normal neurologic exam, they're cleared for discharge from the emergency room. Many studies have demonstrated the safety of ED observation period. However, the length of the observation period is highly variable, and it is unknown whether observation period is even necessary. The purpose of this study was to describe our MBIG-1 population and determine the utility of ED observation period. We performed a retrospective review of trauma patients 15 years or older with traumatic intracranial hemorrhage at 2 level 1 trauma centers from January 2014 to April 2022. Exclusion criteria include GCS less than 13 and penetrating injuries. Our primary endpoints were clinical deterioration and readmission. Secondary endpoints included radiographic progression and neurosurgical operative interventions. A total of 359 patients were included in MBIG-1 category. Mean age was 56.1 years. About half of them were female. Mean ISS was 11.6, and median arrival GCS was 15. The most common type of intracranial hemorrhage was subdural hematoma, followed by subarachnoid hemorrhage. 75.5% of the patients received neurosurgical consultations, and none of the patients required operative neurosurgical interventions. The median number of CT scans were 2, and among those who had a repeat CT scans, 14.3% had radiographic progression. However, none of these patients had clinical deterioration nor required neurosurgical interventions. We had 2 mortality in our group, none of which were related to traumatic brain injury. So over the 8-year study period, 359 patients met MBIG-1 category, and 5 patients developed clinical deterioration and/or readmission. 2 of these patients had clinical deterioration, but none had radiographic progression and did not require any neurosurgical interventions. 4 patients were readmitted. 1 had a new intraparenchymal hemorrhage. Second patient had new temporal lobe contusion. Third had acute encephalopathy without any CT changes. And 4th patient had an intracranial hemorrhage that was thought to be due to stroke and was discharged and then readmitted with recurrent stroke requiring thrombectomy. Then we compared patients who had uncomplicated course with patients who had clinical deterioration and/or readmission to identify any risk factors associated with poor outcomes. And we found no differences in age, gender, injury severity score, arrival GCS, and the types of intracranial hemorrhage were similar. Blood alcohol level was higher in the uncomplicated group. Both groups received a similar percentage of neurosurgical consultations. Both groups did not require any operative interventions. The total number of CT scans and the percentage of radiographic progression were also similar, and no difference in mortality. But this could also be due to the lack of power because one group only has 5 people. That could be one of the reasons. So in summary, our study demonstrated that no patients with small volume intracranial hemorrhage require neurosurgical interventions despite a small subset of patients having radiographic progression or clinical deterioration over the study period. Patients who meet MBIG-1 criteria with GCS of 15 may be managed safely without ED observation period or transferred to a high-level trauma centers only to be discharged from the emergency room. I would like to thank Southwestern Surgical Congress for the opportunity to present our work, and I will now take questions.
Thank you. The invited discussant is Dr. Justin Regner.
Thank you so much. Well-written paper. Often you get to review papers and you have a lot of comments on, simple stuff, but y'all's is excellently written. I had something previously written to say here, but then I'll have another idea. At any rate, I really appreciate y'all's focus on transitioning care of patients from the ED to home. Since our hospitals across the US now and our EDs are so full, I think most hospitals are trying to push any inpatient to an outpatient status, and y'all kind of transition the thought process on this to an outpatient management motif. Having said that, I do think there are some things I personally would like to know more. I think when you look at the MBIG1 group, it's a gigantic group population, from the 20-year-old that maybe had a motorcycle accident to the 90-year-old that may have a UTI that fell and has a small head injury. So you have two very disparate populations that you're trying to apply a very specific guideline on. And so I think my first question would be, what would be the next step to tease out the appropriate patient population for safe discharge from the ED versus patients that, while they may have an MBIG1 criteria, they have other markers of comorbid conditions that probably deserve some further ED or inpatient workup to prevent further loss of life or injury. I specifically would like to know at some point when y'all redo this, what the 30-day readmission is and 30-day all-cause mortality is, specifically for the age 65 and up. Because we know elderly fall in at least three big buckets: mechanical, some sort of sinkable event, or an infectious event. And so I think that would be important information to have. Regarding that, when y'all discharge these patients home, is a friend or a family member expected to be able to perform neuro exams or observe the patient for 24 hours? Do y'all's emergency departments provide a 24-hour home phone call to determine their neuro exam the next day or how they're doing? When it comes to mechanical falls on the elderly or sinkable events, does your ED have the ability to have PT or OT assess the patient to determine their future fall risk and prevent recurrent falls? And then does your institution send MBIG1 patients home on anti-seizure prophylaxis? And the final question is, obviously, when you do the MBIG1 and you have a transferring hospital send it in, like I've received those calls numerous times. Oh yeah, the patient's got a subdural. Well, how big is a subdural? I don't know. It's parafalcine, it's paratentorial. I don't know. It's just really there. I guess, who reads these CT scans and provides the referring or the tertiary center a reads that they know this is truly an MBIG1 patient, which would be safe which may be safe for management at the referring facility. Thank you.
Thank you for great feedback and questions. I think it would be a great idea to kind of divide, and I agree that this MBIG1 population has like all sorts of mechanism and age group. It would be interesting to kind of stratify and do a subgroup analysis. We will look at 30-day readmission and mortality. That is something that we did not look at. Regarding whether friends and family are doing the neuro checks, they're given strict return precautions, but they're not necessarily doing a neurologic exam. We don't do any 24-hour phone calls, but our trauma nurse will schedule a follow-up phone call or a visit within 7 to 14 days, unless they have an appointment with neurosurgery departments, and kind of do a follow-up survey. We attempted to look at those, but the compliance wasn't that great, so we did not publish that study. And when patients are seen in the emergency room and they're deemed, the emergency room or the trauma service will determine if they would need PTOT or speech cog eval, and if they are, if we think it's beneficial, they will get those evaluations. And usually MBIG1 populations do not require anti-seizure prophylaxis. And in terms of the transfer, who reads those CT scans, our neurosurgery colleagues would, especially for the outside scans, for the inpatient or for the scans that are done at our hospital, our radiologist would write in the read what MBIG1 criteria, and because they met this, which criteria, but if they are coming in as a transfer, our neurosurgery colleagues would take a look at the scans and kind of give us what MBIG1 category they are without a formal consult.
Okay, Dr. Cornwell.
Good morning, Eddie Cornwell from Washington, D.C. Great presentation, important topic. Congratulations on your work. And I think all these papers have great import. as we're kind of modifying care. Let me make a couple comments and ask you a couple of questions to push you along a little bit. I'm not quite yet prepared to dismiss the 14% that expanded their intracranial bleed, even though only 5 patients had clinical deterioration. When we're talking about an area where we're all in pursuit of perfection, it's a never event. Any trauma surgeon or neurosurgeon will remember for their career, a patient that has a small bleed, it expands, they require intervention that's delayed because the patient's not there. So we're kind of pursuing that as close to 0% as we can. And so all of these papers and their cumulative are going to be important. Tell us about the 14%, if you know, did they get, I see your mean number of CTs was 2. Did those 14% then get a third CT and what their outcome was? Second question would be your 2 deaths. You said they weren't related to the bleed. Why did they come to the hospital and what did they die of? Congratulations on your work. It's a great paper.
Thank you for your question and feedback. So the 14.3% of the patients had radiographic progression. However, none of them required neurosurgical interventions. Yeah, we looked at the median number of CTs, and on top of my head, I cannot remember what the most number of CT scans they got. But if they had a progression, they would get another CT in, however many hours, and then the neurosurgery colleagues would determine if they need a subsequent ones. For the 2 mortalities, they were not related to TBI. And one of the limitations of our study is that we didn't look at the isolated brain injury, but rather the whole trauma population. So they had another injury that caused their mortality.
Okay, Anika.
I'll make it quick. Yeah. And sorry if I missed this, but did you look at the time to neurologic decline in those who did? Because we're talking about an ED observation period of 6 hours. So that would be relevant. And then my second question is, has this changed your practice over there? Have you gotten rid of the ED observation period? Have you shortened it? And do you think that's going to make, is that going to be more better or more well received by the ER? So kind of what are you doing with this information?
Sure. When we looked at our 5 patients who had clinical deterioration and or readmission, the 2 patients who had clinical deterioration, it was in like 3-day, 5-day mark. And then even the readmission, some of the patients were actually admitted and were discharged, but then they came back a few days after. So even if we kept them for 24 hours, we wouldn't have detected those changes. And with this data, we have actually gotten rid of the ED observation period last August, and it will be interesting to see what we find.
Thank you very much.
Thank you.
Our final paper this morning is a single center study of endovascular interventions for grade 4 blunt vertebral artery injuries, setting the stage for a prospective randomized clinical trial presented by Walter Biffle.
Thank you, Dr. Barrios, Dr. Tominaga, members and guests. I'd like to thank Dr. Kalps and the program committee for selecting our paper for the privilege of the podium. The astute observers among you will see that the title is different because I took the liberty of expanding what I'm presenting today because we decided there was more interesting material in here than just on the grade 4 injuries. I don't have any disclosures of financial support. I'll tell you about some bias that I brought to this project in a few minutes. Blunt carotid and vertebral artery injuries have historically been recognized as rare yet devastating injuries. And in the mid to late 90s, a lot changed in the area, starting with the report by the Memphis group that they could improve neurologic outcomes after carotid injuries by giving patients heparin. And our group in Denver started screening asymptomatic patients routinely, increasing the incidence of these injuries profoundly and identifying patients in the asymptomatic phase. And in the ensuing 25 years, there's been a tremendous evolution in all aspects of the management of the injuries. The current standard treatment endorsed by the Western Trauma Association as well as EAST is antithrombotic therapy with either heparin or antiplatelet therapy. And to this day, there has been no prospective randomized trial demonstrating superiority of one over the other. But a great area of uncertainty with these injuries is the role of endovascular interventions, both in symptomatic patients, so therapeutic interventions, and in asymptomatic patients in a more prophylactic manner. Now, therapeutic interventions would include endovascular intervention like embolization for bleeding, and this goes back to case reports from the 1980s, and control of symptomatic or hemodynamically significant arteriovenous fistulae. And thrombectomy is now a standard of care for stroke management, although you find very little written about it in trauma patients. On the prophylactic side, stent placement, which can be therapeutic, but the application of stents, as you see on the right side, there's a dissection, and the stent is used to tack down the intimal layer and open up the lumen of the artery. And coil embolization, I don't know if my pointer works, but you can see a pseudoaneurysm there in the lower left, and then it's coil embolized. Sometimes stents are placed to occlude those pseudoaneurysms and avoid rupture of them. Well, the use of endovascular stents had a period of great enthusiasm in Denver in the late 90s into the early 2000s. And well, the current guidelines I showed you earlier, progressive severe vessel narrowing or pseudoaneurysm enlargement, basically recommended by both WTA and EAST. But, you know, again, not a lot of literature. And the Denver group, you know, after early enthusiasm, it cut the use of stents in these grade 2 and 3 injuries from 25% down to 2%. The Memphis group really cut their use of stents, and they reported no change in the incidence of strokes. Well, coil embolization is more of a theoretical construct, and we alluded to it in some early papers. And the thing that triggered this study was a case we had in our hospital where a patient had a CTA and there was a little bit of thrombus seen in the middle cerebral artery and an occluded vertebral artery. And an interventional radiologist took the patient and did a coil embolization of the vertebral artery so that the spine surgeon could theoretically safely do a spine operation. And they didn't touch the MCA clot, which turned into a major stroke the next day. So I said, what are the data supporting this practice? And I got silence from the neurosurgeons and the IR group. Well, a group from Shock published this paper several years ago reporting that peristroke vessel recanalization of occluded internal carotid arteries was seen in 100% of their grade 4 carotid related strokes during the admission. They had 60% of the patients with initially occluded arteries that were seen to recanalize, and that would theoretically allow platelet emboli through. I found one paper looking at the practice of routine embolization of occluded vertebral arteries before spine surgery. And you see in that red box, the preoperative vertebral artery embolization was performed in 14 patients. None of them had a post-op stroke, and it wasn't performed in 9 patients, of whom 5 had a post-op stroke. So that's what's out there on this topic. So we decided to look at what was being done in our hospital because we are a level 1 trauma center and also a comprehensive stroke center. We have a very active neuro-IR group. We wanted to look at the outcomes between prophylactic embolization and antithrombotic therapy for occluded vertebral arteries, but also to look at the mechanical thrombectomy outcomes because we had had several cases of those. The study period was between January 2017 and February 2022. The medical records review included all the details about the injury, the treatment, and outcomes. The injuries were graded based on the Denver grading scale, and the grades I'll report here are the highest grade prior to stroke or endovascular intervention, and all the timing of those studies was recorded. Primary outcome was stroke. We focused on endovascular interventions in the internal carotid, vertebral, and intracranial vessels, and extended Glasgow outcome scale scores were used to grade the neurologic status at discharge. So just to get everybody on the same page about injury grading, this is from the scale that was published in 1999. A grade 1 injury is an irregularity of the intimal lining without any flow limiting stenosis of the vessel. Grade 2, 25% or more stenosis, or the visualization of non-occlusive intraluminal thrombus or an intimal flap. A pseudoaneurysm is grade 3, an occlusion in grade 4, and grade 5 would be a transected vessel with active extravasation. During the study period, we admitted over 7,000 trauma patients. We had 32 carotid injuries for an incidence of 0.4% and 74 vertebral arteries, 1% of that population. So our overall 96 patients, or 1.3% of our blunt trauma admissions, had these injuries. Almost all of them were diagnosed by CT angio. I'll focus your attention here on some of the highlighted things. So the column down the middle, BVI, so the vertebral artery injury group compared with carotid injury group was older. More of them were admitted after a fall. There were 38% who had grade 4 injuries and 80% had associated cervical spine injuries. Among those with carotid injury, pedestrian struck was the second highest mechanism of injury. Over half of them had grade 2 injuries, and 75% had associated traumatic brain injury. The outcomes of interest, the endovascular interventions were performed in 13% of them overall, 16% of the vertebrals and 9% of the carotids. Stroke occurred in 13% overall, 15% of vertebrals, 9% of carotids, and 15% died. None of them were attributed to the carotid or vertebral artery injury. The stroke incidence by grade, 11% of grade 1 vertebral artery injuries were associated with a stroke. 11% of grade 2s had a stroke, and 21% of the grade 4s. In the carotids, 11% of grade 2s had a stroke, a quarter of the grade 4s. And there was one patient with a grade 5 carotid injury. They died in the trauma bay, probably a hemorrhagic stroke, but it was never diagnosed as a stroke. A population of interest is those undergoing C-spine surgery, as it's been considered a high-risk group. 64% of them were on preoperative antithrombotic therapy, none of whom had bleeding complications. 24% had preoperative endovascular intervention, generally a vertebral coil embolization. There were 5 preoperative strokes in these, among these patients, and 1 postoperative stroke after the C-spine surgery. Now, the therapeutic endovascular interventions were all done for stroke. There were, in the ICA, 2 thrombectomies. One of them had a stent, MCA thrombectomy, vertebral embolectomy. All of these patients had a very good neurologic outcome. You see the Glasgow outcome scores. The patient who had the 1, that's a patient I told you about at the beginning. She ended up dying. She had a very good outcome after her thrombectomy, went out to the step-down unit and had an aspiration event. She had advanced directives, and the family said, that's it, nothing more. So we couldn't even diagnose whether she had had a second stroke, but she had a great result after the thrombectomy. So very promising intervention there. And the ones who had the prophylactic endovascular interventions, they were all embolizations, 1 for an AV fistula, the rest were for these vertebral artery occlusions. You see that the top 3 all had strokes. One of them presented with a stroke and was taken and embolized to try to prevent any further events. 2 others were done prophylactically, and the one patient I described to you had the postoperative stroke and MCA distribution. And then the third one, their patient 5, had a cerebellar infarct on the contralateral side that was diagnosed subsequently. All the other patients who had the prophylactic embolization had no events. This is all the stroke patients. I told you about the endovascular intervention patients, and then there were 6 who had stroke who were did not get any endovascular intervention. 1 was sent home on aspirin and came back a day later with a stroke. 3 were not being treated at all. 1 was on a subtherapeutic dose of heparin, and 1 had had heparin held for the C-spine surgery and then came out of surgery and had a stroke diagnosed. The grade 4 injuries specifically, 21% had stroke. I've gone through the prophylactic coil embolizations. Basically, we have clinical equipoise for grade 4 injuries. Both of them had some strokes. The recanalization thing, 55% of these patients with initially occluded vertebral arteries were found to have recanalization on subsequent imaging. Shock trauma reported 60%, so this may in fact be a high-risk situation. So in conclusion, most strokes occur after a latent period, so there is an opportunity to treat them. Antithrombotic therapy is considered first-line therapy and should be instituted as soon as possible. The role for prophylactic endovascular intervention needs to be explored in controlled clinical trials. We just don't have enough data right now. And thrombectomy should be considered in all strokes related to blunt carotid and vertebral injuries. It's not being reported. I don't know if it's not being done, but it does appear promising. The role and adjuncts should be studied in a prospective clinical trial. I thank you all for your attention.
The discussant for the paper will be Joshua Gearman.
Thank you for the opportunity to review and discuss this manuscript. And thank you to the authors for getting me the manuscript in a timely manner. I commend the authors for tackling a complicated problem in question. I agree with your conclusions that the study doesn't really define a clear role for endovascular interventions in cerebral vascular injuries, although I do agree that thrombectomy for patients with occlusion and stroke is beneficial. I do feel that the data trends towards supporting conventional management, which is medical therapy with intervention reserved for patients who become symptomatic. As you said, of the 12 patients who had strokes, 3 presented with strokes and 6 of the remaining 9 patients did not get antithrombotic therapy prior to the strokes. I also agree that the indication for vertebral artery embolization is unclear. I personally would reserve embolization for grade 3 and grade 5 injuries. Prophylactic embolization in 3 of your 8 patients had strokes, and that's a rate of 36%. And you kind of inferred that these strokes didn't have the same distribution as the vessels that were embolized, although the main purpose of the vertebral artery is to constitute the basilar artery, which is then going to supply 95% of the posterior circulation. So I think in those 2 patients, you have to consider that embolization may have contributed to those strokes. And for the 3rd patient, I don't think it was clear in your manuscript that clot in the MCA was already there at the time of the embolization. So I think that stroke was probably just waiting to happen. Okay. So my feeling is that these injuries are dissections and they cause flow limitation and malperfusion, and that's what causes these strokes. And I think patients with an incomplete circle of Willis, which is about 20% of the population, are going to be particularly vulnerable to malperfusion and a subsequent stroke. So since you mentioned this is a call for a prospective trial, I have some suggestions. First, I would separate carotid from vertebral injuries and define them separately. I think every carotid injury is a potential problem, and I don't think that's necessarily true for vertebral injuries due to vertebral anatomy and the fact that people have dominant, where one vertebral artery is large and supplies most of the supply to the basilar artery, and codominant, where you have 2 equal vertebral arteries. Unilateral injuries to codominant systems and injuries to non-dominant or atretic injuries, I think, are lower risk for problems, whereas bilateral injuries or injuries to a dominant vertebral artery is going to be a higher risk injury. I would also recommend a complete evaluation of the cerebral vasculature, including an evaluation of the circle of Willis, because 80% of patients who have a complete circle of Willis, I think, are going to be protected from malperfusion. All right, so I'll get to my questions since I rambled on a little bit. So of the patients who had strokes, were they embolic with thrombus found distal and remote from the site of injury? Or were they from malperfusion with thrombus adjacent to the injury?
And did you get imaging to follow up and evaluate that? That's my question. Congratulations on your paper, on your study. It's a tough one, I think.
Okay, well, thanks a lot for your comments and the questions. I'll answer the question first. It was a mix. The patients who had strokes, there were some with distal emboli found, and there were some both in the carotid and vertebral circulation where there was that proximal occluded artery, so probably a malperfusion situation like you suggest. You bring up a really interesting point about the distribution, and it was interesting for me going back and reading through these charts and the notes and, piecing together the timelines. And in one of the cases, an interventional radiologist, one of the neurointerventionalists had been called to embolize a vertebral artery. He said, well, I don't think this is a good idea for, these various risks that can occur. And then a subsequent note, the trauma surgeon, not you, Dr. Tominaga, but one of our colleagues talked to and said, no, we really want this done. And but he brought up the issue of embolizing a dominant vertebral artery could change the flow dynamics in the whole circuit, and it's not something to be just done willy-nilly. And so I think that there's a lot to be answered, and yeah, any stroke after an endovascular intervention ought to be considered in some way related. And I agree with you. We said they're not in the same distribution, but it's all a circuit, and so we got to pay attention to that.
So great job, Walt. Alicia Mangrum from Phoenix. So this is such a devastating thing when it happens. I remember a young kid, 18 years old, a high school star, and he got crushed his mandible. And then he ended up having a stroke, and nobody would have ever thought that would happen. So when it's real, it's just real. It just takes you like, man, what do we do here? And so to give people antithrombotics, okay, we can do that. Give them heparin, Lovenox, aspirin, what's the treatment? We can do that. Where we have the real problem is there are not enough people that are even willing to do the interventional radiology, antithrombotic. I mean, you have to have a lot of guts to go up there and got it. And we can't find that. So in the interim, while you're trying to, we have it. We can sit down. We have interventional radiologists that'll do that, but everybody doesn't have that. And so they got the Denver criteria. And these are the people that blah blah blah. We can put them on aspirin. We can do that. But should there be a mandate that they have to be shipped to a place that does this? Because like I said, when it's devastating, I'll never forget this 18-year-old basketball player who had a horrible mandible fracture and stroked out. He was stroked out. So what do we do?
Yeah, well, great point. And I will say that one of the things that really jumped out of our data is how few of these patients were on antithrombotic therapy when these events occurred. That has got to be an emphasis. And no spine surgeon wants their patient on antithrombotic drugs. No neurosurgeon wants to see a TBI patient on it, but the alternative is not good. So we need to be better about that. And that's the conclusion of all these papers, the shock paper. So, recanalization occurs, but the solution isn't necessarily coil embolization. It's early antithrombotic therapy to prevent it. As far as shipping patients, I would not say right now there's any justification to ship a patient for a prophylactic coil embolization. I would not recommend that. I think we need to study it and just focus on the intervention. Now, as far as a thrombectomy after stroke, well, maybe if they can get to a stroke center in enough hours to make a difference, that would be something.
And when we say antithrombotics, this 81 milligram of aspirin ought to be just shot in the foot. 300, at least 325. I mean, anyway.
Yeah, the aspirin resistance is an issue.
Dr. DiGiorgio.
Yes. Well, first of all, I want to congratulate you on really a lifetime of work in this area that has really put this disease on the map. So congratulations on that. What is your strategy long-term in terms of how do you follow these patients and how long do you keep them on antithrombotic therapy?
That's a great question. And our current thinking is aspirin or another antiplatelet drug. And from the beginning, we would try to do re-imaging at about 3 months' time, but in some patients, some of them come in on antiplatelet therapy and they're going to be on it. So I don't feel compelled to bring those patients back periodically for re-imaging or anything, but I think long-term aspirin is really the way to go until you've documented that the injury's gone.
Okay, thank you very much. We went a little over into your time.